Good afternoon, everybody. My name is Patrick van Renen, and I'm a pediatric gastroenterologist at the University Medical Center in Groningen, the Netherlands. The ECCO-ESPGHAN guideline update for the medical management of Crohn's disease was published in the Journal of Crohn's and Colitis and is open access. In the end of this presentation, I will provide a QR code. If you scan that code, you will be channeled to the website of JCC for a free download of the guideline. In this presentation, I will highlight the most important changes compared to the 2014 guideline. The first guideline, with lead author Frank Rummel, has been cited by 206 PubMed registered articles. The following clinical questions will be answered in the guideline update. 1. What is the treatment target and what surrogate measures can be used? 2. How to choose the first induction therapy? 3. What are the options for maintenance therapy? 4. What to do when your first choice induction therapy fails? 5. How to get the most out of an anti-TNF treatment? And 6. What to do when anti-TNF therapy fails. Let's start with the treatment target in the new guideline. We have moved away from the old treatment goal, clinical remission. Mucosal healing, rather than clinical remission, is associated with favorable long-term outcomes. Although histological remission is considered an even deeper remission, it is currently still controversial as a treatment target in Crohn's disease. This table shows that endoscopy is the gold standard to diagnose mucosal healing. It has good test validity, is responsive to changes in the severity of inflammation, has a good signal-to-noise ratio, but repeat endoscopies to evaluate resolution of inflammation are impractical. There is an increasing demand to replace invasive procedures with surrogate non-invasive markers to evaluate mucosal healing. Fecal calprotectin has good validity and responsiveness and is a practical test. It scores better as an isolated surrogate test for mucosal healing than CRP and the weighted PC-DIE. CRP and clinical activity indices, such as the PC-DIE, have poor validity when used in isolation. However, a composite score of fecal calprotectin, CRP, and PC-DIE is currently considered to be the best suitable non-invasive test to evaluate the response to treatment. The choice of the initial induction therapy is critical. In patients with a pure luminal Crohn's disease without additional risk factors, first-line induction therapy is either exclusive enteral nutrition or corticosteroids. In patients with predictors of poor outcome, including growth delay, extensive disease, perianal disease, or stricturing disease, upfront anti-TNF is advised. The idea behind this advice is that chronicity of inflammation and progressive bowel damage may be reduced when the disease is optimally responding to anti-TNF therapy in the early years of the disease course. What are the options for maintenance therapy? Methotrexate and thiopurines are equally effective in maintaining clinical remission, but there are concerns around the long-term safety of thiopurines. The absolute risk of malignancy in IBD patients treated with thiopurines is small, but cannot be neglected. The main risk is for developing lymphomas and non-melanoma skin cancers. The benefits of long-term immunosuppressive regimens should therefore be considered on an individual patient basis. To date, no such risk has been detected with low-dose once-weekly methotrexate as concomitant immunomodulator. In children with low-risk Crohn's disease who achieved clinical remission, monotherapy with maintenance enteral nutrition, that is at least 50% of the daily energy requirements, can also prolong remission. What to do when your first choice induction therapy fails? If remission is not reached in the first 12 weeks, the expert panel suggests not to waste time with another first-line induction and advises to step up to anti-TNF therapy. If the treatment target is reached within 12 weeks, but the disease flares while on maintenance therapy, then reinduction with first-line therapy can be attempted before stepping up to anti-TNF therapy. The central theme here is no lingering. In other words, do not delay a step up to anti-TNF treatment longer than necessary. Tricks to get the most out of an anti-TNF treatment are shown on this slide. Remission is maintained longer when infliximab is combined with an immunomodulator. The available evidence overall suggests that adalimumab monotherapy is appropriate when started as a first anti-TNF agent. Furthermore, TDM-guided monitoring, that is, measuring drug levels, is considered more effective to get the most out of an anti-TNF treatment than empirical dose escalation. If you start with measuring drug levels in the induction phase, followed by dose optimization, you may reach therapeutic levels earlier. This is especially of importance for children with perianal disease or those with an expected accelerated clearance of the drug, such as children below 30 kilograms, those with extensive disease, and those with low serum albumin. TDM is usually done at the end of induction, that is, before the fourth infliximab infusion, when the target trough level should be over 5 micrograms per milliliter. In patients at risk for accelerated infliximab clearance, an infliximab concentration over 25 and over 15 micrograms per milliliter at infusion 2 and 3 respectively are associated with better outcomes. Early proactive TDM in adalimumab users is done at week 4, that is, before the third adalimumab injection. What to do when anti-TNF therapy fails? First, you have to find out why it failed. For that purpose, trough levels should be measured. In case the trough level is in range, you probably deal with a pharmacodynamic loss of response, which means that the current anti-TNF agent is not effective. In that case, there is no other solution but to switch to an out-of-class biological. In case the trough level is too low, either one of the following situations apply. You may deal with pharmacokinetic failure, which can be solved by simply escalating the dosage. When anti-drug antibodies are present, you deal with an immunogenic failure. With low titers, the remedy is to escalate the dosage and to add an immunomodulator, if not yet done. With high anti-infliximab antibody titers, you may consider switching to adalimumab. This slide shows therapeutic options after anti-TNF failure. In fact, only one option is supported by the expert panel. Ustekinumab, a monoclonal antibody targeting interleukin 12 and 23, has demonstrated efficacy for induction and maintenance of clinical remission in randomized controlled trials in adult patients with active Crohn's disease, including those who had previously failed anti-TNF therapy. Data on ustekinumab efficacy in pediatric Crohn's disease are still limited. Target trough levels of ustekinumab are not yet well established. Vedolizumab is a gut-selective humanized monoclonal antibody targeting the alpha-4 beta-7 integrin that is effective in patients with IBD who are refractory or intolerant to systemic steroids, immunomodulators, or anti-TNF agents. Vedolizumab is effective in both Crohn's disease and ulcerative colitis. Anti-drug antibody development is uncommon. Severe adverse events leading to discontinuation of treatment with vedolizumab are rare. Vedolizumab use is not associated with increased risk of opportunistic infections or malignancy. The available literature does not show any benefit of the use of probiotics or fecal microbiota transplantation in patients with Crohn's disease. In conclusion, new themes in this guideline update include 1. The presence of predictors of poor outcome, the so-called POPOs. When not present, then you can try to induce remission with exclusive enteral nutrition or steroids. When POPOs are present, upfront use of anti-TNF therapy is advised. 2. When the treatment target, low values on the composite score of fecal calprotectin, C-reactive protein, and PC-DIE, is not reached within 12 weeks of first-line therapy, do not waste more time but consider an early step up to anti-TNF. And 3. Close monitoring is necessary to evaluate the response to treatment. This includes serial fecal calprotectin measurements and early proactive TDM. This guideline update was delivered by an outstanding and dedicated team of 25 experts representing major European, Canadian and Israeli centers in pediatric IBD care. We formed 10 working groups, reviewed the literature until the 1st of March 2020 and generated provisional guideline statements. The 30 provisional statements and the supporting evidence tables were shortlisted based on the clinical importance for the medical treatment of Crohn's disease. Some statements were further refined during pre-corona face-to-face meetings and then subjected to a vote. The statement was considered as final when at least 80% agreement was reached during voting. 8 provisional statements were ultimately rejected and the remaining 22 statements contained in this guideline. Each statement is framed and followed by a discussion of the evidence. Practical guidance sections complement the evidence by providing additional information not covered by the statements. Once again, I thank all who contributed. Thank you for your attention. You can scan the QR code for a free download of the published guideline. Please inform the Congress participants about this presentation using Twitter and this hashtag. In case you want to contact me by mail, here's the address. Enjoy the rest of the Congress.